In part 2, about discussing neuromuscular disorder myasthenia gravis, we will talk about the clinical features of the patients. As you can see, the patients, they have a cocktail or mixture of neuromuscular symptoms due to the inhibition of the acetylcholine receptor at the neuromuscular synaptic membrane. Usually they have muscular weakness. This muscular weakness can attack a group of muscle, unilaterally or usually bilaterally. Usually, for example, both of lower limbs or both hands or both eyes, etc. But it can affect unilateral sites. As we told you before, 20% of the patients, they may present with ocular myasthenia gravis. About 20 to 30%. They have only pure manifestations, but late at the disease, at later stage, majority of the patients, they have ocular manifestation. Later in the disease, after 2 years, majority of the patients, they will have ocular myasthenia gravis. The patient may have oropharyngeal muscle weakness, respiratory muscle weakness, difficulty in chewing, difficulty in talking, and difficulty in swallowing. The musculoskeletal limb weakness in myasthenia gravis presents usually in 10% of the patients, and usually it is generalized. But can be unilateral. But usually it is generalized, and rarely it occurs to a special group of muscles. And very interestingly, that the weakness is really fluctuate. The weakness fluctuates during the time. Sometimes, as the patient goes out and work and etc., their weakness will increase. Our patient, we presented to you in the first slide, when almost in the middle of the day, he stopped his car. He was unable to continue. At that time, he was really at the top of his crisis. By 2 years, most of the patients, they will have ocular muscular weakness, they will have oropharyngeal muscle weakness, and they will have limb weakness. By 2 years. If the patient is left without a treatment, the mortality is 30%. The mortality is 30%. And as we mentioned to you, that the severity of the disease fluctuates during the time of the day. Very interesting point. What are the precipitating factors for acute myasthenia crisis, the patient? But many factors had been identified, but sometimes we are unable to reach really diagnosis. Can be emotional upset, systemic illness, infections, hypothyroidism, hyperthyroidism, pregnancy, drugs, and fever. Pregnancy drugs. Always you ask about the new drugs started with the patients. And fever, infection is a very well known established. And here's an interesting point, in the neuro-ophthalmology clinic, some of our neurologists, they like to try Tensilon test. Usually we give it IV, hydrophorium test or Tensilon test, and on 3 doses, 2 and 4 and 4. And if you repeat the doses of Tensilon test, the chance that you'll have nausea, vomiting, or palpitations high, but usually it's a transient. We use a really very small dose for the patient. We start by 2, and then after 5 minutes we give 4, and then after 5 minutes we give 4 milligram. Also, it can be given IM, newstigmin. It's really anti-acetylcholinesterase inhibitors. We can give 0.022 milligram per kg IM dose. For example, if the patient's weight is 70 kilo, we give 1.5. If the patient is a big guy, his weight is above 90, we give 2 milligram IM, and then you have to wait for 10 to 15 minutes for the drug. Oral pyridostigmine had been used as well as for a short period of time. For example, you give the patient from 60 milligram to 1,500 milligrams. So variable dose can have been used, but not really encouraged much. But anyhow, usually the popular one is IV Tensilon test. Please listen to this video clip about giving the Tensilon test for those patients.
Now what we're going to be showing you in the next two examples are patients with myasthenia gravis, predominantly with ocular myasthenia, and we're going to take you through the Tensilon test. So here's the baseline exam. There's bilateral ptosis, and you'll see that there's bilateral duction deficits as well. This patient is apparently fixating with the right eye, and there's a left hypertropia, but the vertical ductions of that left eye are impaired as well. Now these examples are long, and they're basically on this tape to show you that sometimes you have to observe the response to Tensilon over prolonged periods of time, and if you're confused about whether or not there's a response, it's not a bad idea to get an objective observer in the room to see the patient before and after. Now what we do in the clinic are take still Polaroid photographs to document the patient's eyes before Tensilon and then to document the eyes after Tensilon. And this can also help because when you're the examiner and performing the Tensilon test, you're spending a long time staring at the eyes, and if you're looking for subtle changes, it may be hard to tell. So I'm going to allow you to watch a little bit. This is after Tensilon, and I think that you can see there's a dramatic change. The ptosis has resolved somewhat. Actually, it's quite dramatic. And although the screen is split and the eyes aren't symmetric, I think you can see that the left hypertrophy is gone. And look at that, the left eye, the vertical ductions are very nice. This patient's able to get that eye up very well and can infraduct well as well. So this is a nice positive Tensilon test. It's confirmed the diagnosis non-invasively. Now what we're going to see is that the effects of Tensilon are fairly short-lived. As we keep examining the patient's eyes, you'll notice that the lids start to fatigue again and ptosis will develop. The patient will develop that hypertrophy again.
There we go.
So bottom line, as you watched Dr. Jacobson in his recorded episode of giving IV Tensilon test, the dose is 2 and 4 milligram. You have to observe for improvement. You know, the ocular manifestations, as you mentioned, is ptosis, diplopia, and orbicularis weakness. Ptosis, diplopia, and orbicularis weakness, and you may watch Dr. Andrew Lee in his neuro ophthalmology channel describing myasthenia gravis. Okay, so as we said, 10% of the patients with myasthenia, they have thymoma. It's a very good point of debate. If you resect thymoma tumor, will the patient improve or not? But usually the discussion is should happen with the family. Take the discussion with the family because there is a chance of improvement. There is a chance of improvement. The patients will have less drugs, therapy dosage. They will have free period time, doses, etc. This will be discussed in the next chapter. The thymus gland is the primary lymphoid organ. As you can see, it's in the superior mediastinum area, and the thymus gland here is in green color. It's an active until puberty, and then it shrinks and will be replaced by fat. As you know, the thymus function in the autoimmune maturation of the body by producing the thymosin hormone, which plays a major role in maturations of the lymphoid system, maturation of the T lymphocyte. It plays really a major role in maturation of the beta lymphocyte into plasma cells. 10% of the patients with myasthenia gravis, they have thymic tumor. That's why CT chest is mandatory workup for those patients, because some of the patients, they have thymoma. 60% of patients, they have only thymus hyperplasia. There's no enlargement of the gland, etc. But you know how the other patients may have myasthenia gravis with a normal thymus gland. And here's a picture of one patient with a very large thymus. Look at the thymus. It grows into the superior mediastinum and then goes anterior to the anterior mediastinum in the front of the heart, and then goes to the left side, and it's really occupying the left side of the hemothorax. So sometimes the thymoma is not really enlarged. Sometimes it's enlarged mainly in the anterior and superior mediastinum, and in other cases the thymus really enlarged to a great degrees. It's really a good matter of debate whether you do surgery for those patients or not. What's the indication of thymectomy in those patients? And discussion should happen with the family, because some patients may continue to have a chronic disease despite of the surgery. Thank you very much.